So I'm going to be talking about Elsie's case study. So to introduce you to the patient, she is a 32-year-old female. She is 69 inches tall. Her current body weight is 124 pounds. Her usual body weight is 135 pounds, and then her ideal body weight is at 145 pounds. She has a BMI of 17.4, which does put her in the underweight category. So she was admitted with some chief complaints of abdominal issues, poor appetite, nausea, vomiting, diarrhea, fever, night sweats, rash on her legs, general malaise, a 16-pound weight loss, and also to be noted a 3-month history of the abdominal issues, which includes abdominal distension. So her primary diagnoses include the hantavirus pulmonary syndrome, valley fever, short bowel obstruction secondary to ascarsis, and then her secondary diagnoses include severe protein calorie malnutrition, hypotension, pulmonary edema, petechia, purpura, hematuria, a stage 3 pressure area of coccyx, and then disseminated intravascular coagulation. So just to give you some more background of Elsie, so she came in with all these abdominal issues, and then some ultrasounds were done and some CT scans, and they later on found that there were some parasites within her small bowel. And so the parasites did cause an infection that did spread to her intestines, including the jejunum and the duodenum. So she also has a diagnosis of Crohn's disease in her early 20s, and then she did have a history of a terminal ileal resection of 79 centimeters of the ileum portion. She has a vitamin D deficiency as her past medical history that should be noted, and then also vitamin B12 deficiency in her past. So to discuss the pathophysiology, so right now Elsie has all three segments of her small bowel are affected from previous medical history and now the parasitic infection. So the first segment is the duodenum, and it is responsible for the initiation of nutrient absorption. And she had a complete removal of her duodenum. And then the second segment would be the jejunum, which is responsible for absorption of carbs, fats, minerals, and proteins, and also vitamins. And she had 100 centimeters of her jejunum removed. And then the third segment is the ileum, which she had an ileum resection when she was in her 20s. And that is responsible for the B12 absorption, bile acids, and then also folate. So her etiology includes malabsorption and hypermetabolism from the removal of some of the parts of her small bowel. And then she was given an NG tube, but it was not sufficient at the stage of recovery that she was at. So they removed that and then moved her to a PEG tube for feedings. But some of the potential pathomechanisms can include insufficient mechanical breakdown of food components, decreased antral contractility, critical reduction of time for absorption, which is dumping syndrome, impaired digestion and absorption of nutrient components caused by reduced gastric acid secretion, pancreatic exocrine insufficiency or reduced biliary secretion, defects of enteral mucosa with deficiencies or lack of specific carrier mechanisms, critical quantitative loss of intestinal mucosa, and patients that already have the short bowel syndrome. So for the assessment, nutrition-related history, recovery after GI surgery is very important, especially with nutrition. So proper nutrition does mediate the surgical stress, muscle breakdown, and then lipolysis that accelerates wound healing and enhances host defense against microbes. She also does run the risk of anastomotic leakage or surgical site infection, which is always a possibility because they did the surgical connection of the two parts of her small bowel. And then when this happens, when there's surgery issues that arise like the infection or leakage, it can lead to delaying the nutrient care that should properly be in place. So for her, it could include, postponing oral food consumption for several weeks, which is very important for her. So she already does have a malnutrition risk with the protein, but this GI surgery puts her at even more of a risk for even further complications with malnutrition. And then the gut does act as an immune organ. So gut-associated lymphoid tissue, including Peyer's patches, intraepithelial lymphocytes, and lamina propria lymphocytes contribute to the largest immune organs in the body. So they are very important. So some nutrition-focused findings include immune defects that occur in absence of enteral feeding. So gut and hepatic MNC changes occur only in a few days after starting nutrition feeding, and these changes are reversed, resulting in normalization within a few days after restarting oral feeding. Glutamine deficiency is also something very important. So new parenteral nutrition formulas are now including the glutamine dipeptide to prevent diarrhea and then also to preserve gut morphology and immunity. So I would definitely recommend that she has those included. And then arginine deficiency is a big possibility. So arginine stimulates the growth hormone secretion, and it is metabolized to polyamine, and it enhances collagen production, which thereby accelerates the wound healing. So this is definitely essential for her recovery. So for my PES statement, in Elsie's case, it is evident protein energy malnutrition as related to malabsorption and hypermetabolism that resulted from 22 centimeters of the entire duodenum removal and 100 centimeters of proximal portion of the jejunum removal, and a history of terminal ileal resection as evidenced by less than 50% of needs being met for 5 days, with a 13% weight reduction from 140 to 124 pounds, with days of nothing by mouth using the NG tube that was removing nutrients rather than distributing them properly. So for intervention and nutrition post-operation, I would recommend that B12 levels are monitored due to the ileum resection. So with the ileum resection of 100 centimeters in her case, 60 centimeters or more can put the patient at a very high risk for B12 and fat malabsorption. So those will need to be checked at 3 months post-op, 6 months, and also 1 year post-op, just to make sure that levels are maintaining what they should. So the levels should be at 255 picograms per milliliter at the 3-month mark, 265 picograms per milliliter at the 6-month mark, and then 950 picograms per milliliter at the 1 year mark, and that puts her at that point in the normal ranges for B12 levels. So that would get her to a healthy range. Fat-soluble vitaminosis due to the entire duodenum removal is a big possibility as well. So all of the fat-soluble vitamins need to be taken into consideration, and then labs need to be done for those as well. So vitamin A is a known agent to be required for epithelial tissue development, and it also facilitates normal wound repair. So this is definitely a very essential vitamin for her recovery period. So they should aim to bring her to about 700 micrograms, and then vitamin E should be supplemented daily with 400 IU. For vitamin D3, or for vitamin D, specifically D3 though, I would recommend 3,000 IUs daily. This will help her to absorb more calcium in her intestines as well. And then for calcium, I would recommend 1,800 to 2,400 milligrams daily. For vitamin for vitamin K, I would recommend 5 milligrams daily following the surgery, and then maintaining that for about a year at least. But vitamin K does play a huge role in blood coagulation. And then the macronutrients and vitamins that are absorbed in the jejunum will also be affected from her partial removal. So she should start with 60 grams of protein a day, and then she should work up to about 100 grams of protein a day if she can. And then it is just very vital that, you know, micronutrients and macronutrient levels are just monitored continuously after the surgery, just to make sure everything maintains what it needs to in order to heal. So for that, I will be using the Vital HP formula for the enteral tube feeding, and I did choose this one because I like that it was a peptide-based therapeutic nutrition for tolerance. It is good for patients with malabsorption and impaired GI function, which is exactly what Elsie has going on. So that puts her at 1,140 calories a day. So her total protein should be 126 GM, which will be about 37% of her total calories. Her total carbs should be at 160 GM, which puts her at about 41% of her total calories for the day. Her total fat should be 33 GM, which is putting her at 22% of her total calories. And then for her fluids, she will need feed water of 1,204 milliliters, a water flush of 900 milliliters, total fluids of 2,104 milliliters, but her daily needs will be 1,974 milliliters. And for the fluids, she should start at 20 milliliters an hour and then titrate by 10 to 20 milliliters every hour, or every 4 hours, I apologize, to get to her goal. And then 150 milliliters of free water flushes for every 4 hours as well as a good starting point. So to conclude this case study, Elsie did have ileal resection, her entire duodenum removal, and then partial jejunum removal that places Elsie at a very high risk for continued malnutrition, as she already did come in with the protein malnutrition. But proper nutrition recommendations and supplementations can help her reach the appropriate levels in order to recover fully and to repair what's already been affected so much.